Humphrey and Dr. Nina Kottler.
We're really thankful that you all can join us today. We're going to kind of share some insights of where we see things going with AI in radiology. And we'll kind of have some interaction with Dr. Kottler and myself. We'll cover all this in about 40-45 minutes and then take some Q&A at the end. Just to kind of give you a sense of our agenda for today, this is kind of what we're looking at. We just covered the introduction. We'll talk about the evolution of AI in radiology, kind of give our crystal ball predictions as to where things are heading. We'll talk about some of the challenges and the possibilities, some different reasons why AI adoption has only been deployed in limited use cases thus far, but why we think that's kind of at a tipping point and it's going to start to change dramatically in the future here. We'll talk about some clinical examples of how AI is being used in both a hospital setting as well as a private practice setting. And then we'll talk about some kind of key components of successful strategies and how to deploy AI. And then we'll have some closing thoughts and questions. So with that, we'll just jump right in. And this is a session that we're offering continuing education credit for. So at the end, stick around if you want the continuing education. AHRA can provide that for you. You'll have to answer a few quick questions to get that credit. In terms of our learning objectives, again, we're going to discuss the evolution and the current state of AI. You'll learn the opportunities and challenges for AI and why it's only been adopted in a few cases so far, but it's on the rise. Again, we'll discuss some case studies, share our crystal ball predictions, and then hit some key considerations. From there, if you could advance the slide, please. I'll go ahead and jump right in. So I don't know how long everybody's been involved in radiology, but when I first got exposed to radiology, this is kind of what the world looked like. Maybe people weren't sitting on their desk at the time, but you had physicians that were in the center, kind of the command center of the hospital. The radiologist was considered the doctor's doctor. We were using, dated technologies now, the equivalent of, 8-track, I guess. But physicians were reading on light boxes and everything was plain film. They were using dictaphone. So the technology has changed a lot, but the role of the radiologist has always been at the center of healthcare and has been the doctor's doctor. If you think about all the other ologies that have to interact with radiology, a radiologist has to know a lot about every type of specialty. And it's very important that we have the right tools and that we are able to advise other doctors. However, back in the day, it used to be that the other physicians would come into the reading room and ask questions, and there was a lot of interaction back and forth. And now it's moved to, radiologist is often just kind of working a little bit more remotely or in isolation in the reading room. Because of the technology, there's not as much interaction going on between, face-to-face and person-to-person with the radiologist. In terms of the technology that has changed, we've come a long way, and a huge evolution occurred, 20 years or so ago in the early 2000s when PACS came out. And PACS really began to give the radiologist, much greater tools, a better view of things, the ability to read faster, more accurately, and it really changed the game from a radiology perspective. But once we had the technology, then there was this kind of push to read faster, and there was less interaction with referring physicians. But it was a good thing that we were reading faster because imaging services really spiked and grew dramatically over that decade. From 2000 to 2011, you can see the increase in imaging services and Medicare. It grew 80% over that decade. But the number of radiologists only grew 20 to 30% over that time. So there was a huge gap between the amount of exams that needed to be read and the number of radiologists who were able to read them. And it's a good thing that we had the tools to be able to keep up with that demand. It was still difficult, but without those tools, we would have had a real crisis because of the increase in volume and the shortage of radiologists. So the technology really helped us there. But again, the goal was to read faster. We've got to keep up. There's so much volume. And whenever you read faster, you're going to compromise in some other areas. And we kind of lost some of the luster and some of the value of the radiologist having that relationship and really being able to advise as much. It became a lot more transactional, just trying to keep up with the volume. And we believe that the volume of imaging is going to continue to increase over time, and we're going to have to continue to find new tools and new technologies to keep up with that. More than half of radiologists right now are at retirement age. And so we're facing a coming shortage of radiologists over the next decade, as well as the population is aging. So there's going to be, a greater demand for imaging services. So kind of the same place that we saw ourselves in back in the late 90s, early 2000s, kind of right back to that same point again. And this is where we think AI is going to be that next game changer, like PACS was back in the day. So with that, I'm going to turn things over to Dr. Kottler, and she's going to share some of her perspectives on AI and where we're going. And then we'll come back later and talk about how you can actually kind of implement and what a strategy can be for your organization.
Thanks, Reed. And I live that as a radiologist. I've been in practice for long enough that when I was a medical student, the place that I was in medical school, everyone had alternators. And so everyone was coming down into the reading room. That was that robust conversation between all of the different specialties in radiology. And radiology could be the physician's physician. And we got really great information. So we never had anything in our report like clinical correlation is recommended, because we were doing that correlation at the time. I really agree with you, Reed. I think AI is going to be the thing that transforms us back. Technology does not have to separate us from communication with our other physicians. It can connect us. And I do think that AI has that ability. Now, with that, AI is not seamless. There are some challenges in rolling it out, and we're going to talk through a bunch of them today. You would think that because AI is this great thing, everyone's talking about it, right? There's a huge amount of hype. There's literally billions of dollars being spent on artificial intelligence in healthcare and even in radiology on its own. And with that, you would think it's rolled out everywhere, but it isn't. And there's a bunch of reasons why. We're going to talk through 7 of those today, and we'll go through one by one. With that being said, I don't want you guys to think that this is a doom and gloom for AI. All of these things are surmountable. It's just important for us as consumers and users of this technology to be very aware, because it's important for us to understand so that we can oversee the technology rather than the technology sort of overseeing us. All right, so we're going to go through 7 cases, 7 reasons, and we'll start with the business case. Why aren't we seeing AI everywhere? Well, there's not a great business plan for AI, especially when it first came out. This is a true story, but we're a large radiology practice. The first group that came to us and they're like, hey, we've got this AI algorithm. We're going to be able to do all kinds of things. And I know you think you might not be able to afford it, but the business case is that we're going to replace radiologists. And we're like, well, we're a radiology practice. That's not our goal. We're not going to replace radiologists. And I think the business case has changed. It's not like there's extra money sitting around in healthcare that we can just pay for anything. It has to have a proven ROI. And we're starting to change, at least I'm hearing the vendors, they're all changing from saying, hey, we're going to replace radiologists to we're going to augment radiologists. And depending on who they're speaking with, there's a different business plan. So if they're talking to a radiology practice, a lot of the discussion is about efficiency. How can we gain efficiency for the radiologist so that they can read more cases in less time and with less burnout? And when they're talking to a healthcare system, what they're talking about is how can we increase the amount of dollars coming into the system, either by more patients coming in, by more procedures being done, or more value being created, or by decreasing costs, which is also really important. Let's decrease the length of stay. Let's increase ER throughput. So business plan is starting to turn around, but at the beginning, there wasn't a really good use case for AI. Number two, I don't know if you guys have heard of the Gartner hype curve. So Gartner is an information technology consulting company, and they created this curve that talks about the deployment of new technology and its maturity over time. And it tends to follow a very typical curve. And that curve is based on Amara's law. Amara's law states that we tend to overestimate the effect of technology in the short run and underestimate it in the long run. So here's the hype cycle or the hype curve. The technology trigger in this case is artificial intelligence coming out and being utilized in medicine. That is on the bottom left. You've got time as the x-axis, and the y-axis is visibility within the market. And I think we've already gotten to the point of, well, we've had significant inflated expectations. Back in 2016, Jeff Hinton came out and said, there's not going to be radiologists anymore. It's very clear and obvious that in 5 years, AI is going to take over everything and we should just stop training radiologists now. Well, guess what? 5 years has gone by and it's barely being rolled out. So where are we right now on this hype cycle? I think we've come down. There's been a little bit of negative press, both within healthcare AI and outside of healthcare AI with automatic driving cars, that have put us over that peak of inflated expectations with more realistic expectations. But what's going to happen now, and I'd say this is starting to happen already, but it will happen more over the next year, is we're going to get into the consolidation area where people have been spending huge amounts of dollars to get their businesses going in AI, but there's not a lot of dollars coming in. So some of those businesses are going to disappear. Some are going to connect together. I've talked to different vendors. They've already heard other vendors coming to them and saying, will you buy me? So over the next year, I expect some consolidation, which means that it's hard to pick a winner. Like, how do you know which one's going to be around in a year? Soon we're going to be in that trough of disillusionment where then it's also hard to get out of and begin implementation again. All right, number three, data. We all know that artificial intelligence needs data, and it needs a huge amount of data, and not just any data. It needs structured data that has an answer to it, right? All of our information, all of our data in radiology is unstructured. Our reports are unstructured. Our images are unstructured. We try to add structure to it, but that's just through DICOM and HL7. We don't really have structure. So how do you get data that's structured to an AI system? You have to spend time creating it. And while we all think that our data is nice and beautiful and looks like this, it really looks more like this. Our data is siloed. There's components of data that are only useful for certain systems. They don't talk to each other. None of it is labeled. We don't have a lot of radiologists with extra capacity who really want to go in and make circles around all of these different findings. So getting the data is not an easy thing. Okay, number 4 and 5, we'll talk about bias and context. We only have a little bit of time today, so I'm just going to talk about the 2 most important components that I think are relevant about bias. And this one is the most relevant. If you remember anything from today, remember the sample bias, which causes the brittleness of artificial intelligence. And what is that based on? Well, that's based on the fact that artificial intelligence understands the data that it's been trained on. So if your training data is different than your own data, the accuracy that you're hearing from the AI vendors is going to be very different in your environment. So the question is, how can that be different? Well, let's say you are the algorithm was trained on a certain level of magnet of an MR, and your data is actually on a 3 Tesla magnet and not 1 Tesla. Well, that can make a difference. What if your protocol is different? I mean, it wasn't that long ago that we were giving oral contrast to everyone, and now we're barely giving oral contrast at all. Or maybe the training data had a lot more excretory phase and your data is more late arterial or portal venous phase. Well, that's going to make a difference. What if your scanner is a different brand scanner? That makes a difference. The protocol or even the software on the scanner, if that's different. The quality of your studies versus the quality of the studies that it was trained on makes a difference. And then there's things that you just have no control over. You might have some control over the other stuff, but the patient population that happens to be coming into your door, which may not only be different than the training data, it may also change over time. And then the disease prevalence, COVID didn't exist, or at least the COVID that we know about didn't exist a year and a half ago. Suddenly we have a whole new disease that's coming in, and no AI system would have been able to pick that up. All right, and here's the other component of bias that I think is the most relevant. That one was more about how well is it going to deploy and how accurate is it going to be in your situation, and very much unlike a rad. For instance, a rad walks to a hospital down the street, a radiologist can read seamlessly from one hospital to another, but an AI system, again, it may not work if that hospital data is different. So this kind of bias is about deployment. And when you deploy an AI algorithm or any automated algorithm, you have to watch out for a human bias called automation bias. And automation bias is the tendency that we as humans tend to trust automated systems sometimes more than we trust our own intuition or knowledge. And this happened when GPS first came out. Now, this was many years ago, and I will tell you, this image was not hard to find. There were hundreds of them where people turned the wrong way down one-way streets. They turned into parked cars. They drove into lakes. And you ask them, well, why did you do that? And we say, well, the GPS told me to do it. And that's an example of automation bias. And it may sound silly. You may think, oh, that will never happen to me. This happens to every human. And so we have to be careful when we're rolling out these AI systems that the radiologist or whomever you're rolling it out to is very educated and doesn't let this bias come into effect. And that you can only sort of prevent this or help prevent it through education. All right, so let's talk a little bit about context. AI only understands the context of a situation if it has been taught that, if it's been learned. And this is something that actually happened in my family. So my husband is a huge sports fan. We live in the LA area. And so he bought season tickets to go see the Los Angeles Clippers a few years ago. And when he did that, he suddenly noticed he started getting some advertisements for hair clippers, right? Completely different context. For us, when we're speaking in a sentence about, well, clippers and basketball, we're not going to ever confuse that with hair clippers. But that if that context is not actually taught to the AI system, it's not going to understand that. All right. Number 6, FDA clearance. The FDA is there to protect us. It's to make sure that the safety of the algorithms, the models, as we roll them out, are safe for implementation. And they are testing it. And they've been really a great organization that's been very agile with this new technology. But what they're not able to do is to test it in your environment. They're testing the accuracy over something that they think at least covers a few different hospitals. You have to have some kind of diversity in your patient population, but they have no idea what your patient population is and what your exam population is. So there's no way for an FDA clearance to say, well, that is going to work the same way, and we cleared it from a safety perspective, it's going to work just as well for you. And what we found is that that's not the case. And here's an example of an article that I grabbed from MIT Technology Review back last year, where Google had, and I'm not picking on them because this is true for anyone, but Google had a medical artificial intelligence algorithm for retinal detachment, and that was really accurate. They did a fantastic job in creating the algorithm, but then when they went to deploy it in places like Thailand, it was deployed in situations that they didn't expect. Some places didn't have internet. Some places where they expected a nurse to be doing all of this work was being done by someone else. And so when you don't have an expectation for something, you didn't train your algorithm for it, it's not necessarily going to work. And so the key for all of you out there is it's really important for you to understand how an AI algorithm is going to work in the context of your own environment, your own workflow with your own data, because it may be very different. And frankly, when I talk to vendors, it's nice to know what the ROI is and the sensitivity and specificity of their algorithms, but I don't take that as that's what it's going to be for me. I ask them a lot of questions about the variability of their data to try to compare to see how accurate it will be with me. And frankly, I always end up doing a pilot. Okay, and this is the last one we're going to talk about today. And to me, it is one of the most fascinating things, and it's data orchestration. Data orchestration is really just about moving data. And I never thought about this so much as a radiologist until I started thinking more about artificial intelligence. But you need to move data around to get from wherever it is, your DICOM, your HL7, and a lot of AI systems will need one, either your DICOM or your HL7, or they'll need both and different HL7 messages. So the data orchestration is how do you move your data from wherever it is to the AI, and then also how do you move it from the AI system to wherever you want it to go. And where we send it right now is to the radiologist, like through the PACS system, through their workstation. But you can actually send it to anywhere. We're not limited on that. So orchestration are these green arrows. And what I'm going to talk about today is just the first component of it. So when we send the data to the AI system evaluates that data. What is AI good at? AI is really good at adding structure to unstructured information. And so here it picked out that there's no intracranial hemorrhage on this head CT. It picked out some specific things within the report. So it's adding structure to that information. And once we have structure to our data, we can decide what to do with it. In this case, we're sending it to the radiologist because that's what we do right now. Usually automatically, or we'll send it to a downstream system so the radiologist gets access to it in their workflow. And that's great. But there's a lot of choices. If you have knowledge about what's in your data, you can choose what to do with it. And why is that important? I'm going to limit today just to talk with this. What I'm saying is part one of workflow, which is getting the data from your systems to the AI system, because there's some lessons to learn. And that same thing applies to the second part. Okay, so why is this important? So here's an example. This is a left-hand PA radiograph in a child. And a friend of mine told me about this online bone age algorithm. Now, I will let you know that there is no FDA cleared bone age algorithm, but there is one that won a contest and they did the best and they had a really great algorithm and they put it online for people who want to try it out. So I thought, well, that's great. I'm going to try it out. And I sent this exam to it and it provided really fantastic information. It gave me the predicted bone age. It told me, I knew the chronologic age and I was able to compare it. And it did all of that in 1 second. But I knew what this study was. So I was the data orchestrator. I picked the right exam to send to this algorithm. I thought, well, what would happen if I sent an inappropriate exam? So I just grabbed a mammo, flipped it on end and said, well, what happens if I send this? I mean, it's clearly not even the right modality. Well, the AI evaluated it and it told me it was a 13-year-old 2-month male. Now, if the algorithm knew that this was a mammogram, then it wouldn't have evaluated that. And that would be important for data orchestration. Lesson number 2. So what you might not know is a lot of AI algorithms, they don't evaluate every single series of your image. They usually on a CT evaluate the axial image. On an X-ray, they may evaluate the frontal image. So here's one that evaluates for intracranial hemorrhage. If you sent it this axial study, this actual axial series, it would tell you there's no intracranial hemorrhage. But what if you sent it the sagittal on the same case? That midline falx calcification, which is very clear, and I'm sure the algorithm's been trained on, suddenly looks different when you look on the sagittal. Would the algorithm call it an intracranial hemorrhage? We have to be sure that we're sending the right series. And so we shouldn't be sending that sagittal series. If we knew it was a sagittal, we wouldn't send it to begin with. Here's another exam. Now we have the right modality, right? It's an X-ray. We even have the right view. It's a PA view, but this case it's an adult, right? We see that there's arthritis. Now I wouldn't normally send an adult study without growth plates to a bone age algorithm, but I did, just to see what happened, and it evaluated it, told me that they were 17 and a half years old. Again, if we knew that this was an adult, we shouldn't have sent it. So what have we learned about data orchestration? It's really important to make sure that we're sending the right studies. Now, we have to send the right studies to the right AI, but in the future, we're going to have multiple AI algorithms to choose. So not only do you have to send the right studies to the right AI, you have to choose the right AI algorithm. Now, in my practice, we have 2 AI algorithms that are meant for pulmonary embolus evaluation. One that is meant for really high quality studies. So in theory, anything that's called a CTPA on your HL7 or DICOM should be a high quality study, but they're not all, right? The timing may be off, the cardiac output might be low. And here's an example of a study that is poor timing for the pulmonary arteries, but really good for the aorta. We have another algorithm that is more optimized for low quality exams. So studies normally that aren't meant to be a PE study, maybe a CT abdomen pelvis where you're catching the lung bases and you're doing it in the portal venous phase, or just a CT chest with contrast where you're not really thinking about it, or a study like this where it was meant to be a CTPA, but not the timing was off. You would want to send it to a different algorithm. But if this came across as a CTPA on your DICOM header or your HL7, you may automatically route it to your high quality PE algorithm. If instead you knew that this study was not the best quality, you could make a different choice and you'll get a much higher accuracy if you sent it to this other incidental PE algorithm. But you have to know something about your data in order to make that decision. So this is what data orchestration is about. If you know something about your data, you can orchestrate it in a smarter way. It is essential for us to send the right series of the right study modality for the right patient, adult, kid, to the right AI model. And that is what orchestration can do. Orchestration can tell us what part of our exam to send and to send it to which AI algorithm, as long as it knows something about what's in the data. All right, now, again, not doom and gloom. We could figure all of this out, but it's really important for us to work together on it. We're not going to do it alone with just the vendor rolling it out across our practices. There needs to be cybernetic and human collaboration along with practice or hospital system and vendor collaboration to make sure this works. So with that, let's transition a little bit into the possibilities of artificial intelligence and what can you do with it. And we'll go through a couple of use cases. First of all, when you're thinking about creating a use case, well, what am I going to apply artificial intelligence for? It's much easier to, instead of thinking as radiology as a whole, to split it up into the different components of what we do and what you might call the workflow or the life cycle of an examination, because artificial intelligence can be used at any point along this curve, from the moment where a referring clinician has a clinical question that they want to figure out, and 80% plus of the time they're ordering an imaging study to do that, scheduling it, acquiring and reconstructing, opening it and making sure you're opening the right study on a work list, gathering the patient information, interpreting, reporting, and then, of course, following up and doing peer learning. Every single step of this can be optimized. And there are a bunch of algorithms or models that are already out there that are doing this. We're going to talk about one of those specifically today, and that's what I call, or what is called CAD-T, which is CAD triage. And I'm talking about that because it is the most common type of algorithm out there in radiology, mostly because it is, well, it's about imaging, right? It's about detecting a finding and triaging it on a work list. And from an FDA clearance standpoint, it is the easiest algorithm to get through FDA clearance, so it's the lowest bar. And there's a lot of CAD-T or triage algorithms out there. So what is a CAD-T model supposed to do? Well, if you have a work list, normally we organize that by time remaining. Maybe you've got it organized by stat or non-stat cases, but you don't know what's in the images. So there's no way to organize it from any smarter mechanism. But if you have a CAD-T solution, it will go in and it will evaluate every image on your exam or every appropriate image on your exam, and it will let you know if there's any pathology, any significant pathology. And if it does, it can then move those studies to the top of your work list. So instead of reading just simply by time remaining, you're now reading by clinical relevance. And the more exams that the more findings that we can find with these triage models, the more sophisticated we can get. And it doesn't just have to be AI for these triage models. You could triage based on, the patient's waiting for discharge, or the patient's pending an orthopedic appointment that they need the MRI of the knee read. There's lots of ways to triage triage, and it does benefit. Now, it may have less of a benefit in a SAT patient because you're going to read those probably in 30 minutes, but certainly for your inpatients, which you might not read for an hour or even 4 hours, or for your outpatients, which perhaps is a day turnaround time, it can definitely make a significant difference in those patients. But is that the only benefit? That on its own might not be sufficient. We did a pilot with a couple of triage products, and we found that there was benefit beyond moving the study and actually getting to a pathologic study faster. We found that the AI algorithm helped radiologists pick up studies that they had otherwise missed. And there were in our pilot, which we ran a pilot for 6 months, and we ran it with 2 algorithms. One was to help us detect intracranial hemorrhage, and the other was for PE. The intracranial hemorrhage helped us find 2.4% more intracranial hemorrhages than we had otherwise found on our own. And for PEs, it was actually 4.4%. So a significant amount. The images on the bottom, although they're reversed, the images on the bottom are actual cases that were missed, and they are both quite subtle cases. It could raise the question of, well, is it even providing value? Is there ROI to find these findings? And what if we end up treating these patients and have complications, or you put them in the hospital and you're just spending more money on patients that didn't need it? Maybe we're better off not finding it. And we're gathering more data to have a statistically significant answer for you, but I can tell you already anecdotally that's not the case. So here's my second use case, which is about improved detection. This was a 76-year-old patient that came into one of our emergency departments and came in with altered mental status, no history of trauma or anything. And the AI picked up a finding that the radiologist had initially missed. And we called the patient back. They came back 36 hours later, and this tiny, subtle intracranial hemorrhage, which is very difficult to see, it's actually grown significantly, enough that you can see it's compressing the left lateral ventricle, it's causing left to right midline shift. The patient was symptomatic enough that they needed to have a craniotomy for decompression. So this was a very subtle finding, no history of being on Coumadin, no history of trauma, and yet this patient progressed significantly. So some of these subtle findings are very important, and we can't ignore them. So having an improved detection is helpful. And it's not just for intracranial hemorrhage and PE. There are other things that we know we miss. And here's a table of some of them that I have data for, but this is true generally across the board. The other thing I'll tell you, because as I ran the pilot, I talked to our radiologists about it. They really enjoyed using this product, and they felt like they had less burnout by having sort of a cybernetic buddy help them with these cases. All right. And again, this is not about AI replacing us. We know that, and there's been plenty of studies to show that radiologists plus an AI system together are better than either one alone. I bring this image in. It's a little cheesy, and you can tell that I did the graphics for it. This is from Minority Report, because I want to give a little bit of a glimpse into the future of what our future in radiology is going to be like. And I thought this was just a nice graphical image. Our jobs are not going to be the same in the future. We're not going to lose our jobs, but our jobs as radiologists are fundamentally going to change. We are going to have a significant amount of more data, whether it is through AI systems, whether it is through radiomics, genomics, molecular imaging. All of that data is going to come to a central system. And I believe that the radiologist is best positioned to interpret that, understand where it works, understand where it doesn't. So instead of being the imaging expert and the consultant, they will be the information expert and the consultant to our referring clinicians and also to our patients. With that, I would like to pass it back to Reed.
That's great, Dr. Kottler. Thanks so much. I really appreciate you sharing your insights and learn some really interesting things here. It's exciting to see where this is going. I liked your Minority Report example to pull it all together. Someone actually in the chat screen mentioned Minority Report earlier, so clearly people were kind of seeing where you were going with the message. But yeah, this is great. So I was going to take a few minutes just to talk about AI deployment. This is an area that we spend a lot of time on in our organization at Canopy, just helping hospitals and health systems and radiology groups kind of drive out their AI strategy. And so I wanted to give you a sense of what we're typically seeing in terms of how the AI works, how you would implement this, and how you kind of drive it out for success. So here's a sample architecture that's kind of based on the model that Dr. Kottler just shared. This is a software as a service model. And if you can just kind of follow maybe left to right with me, starting with the PACS, the vendor neutral archive, the modality router. So as the images are coming off of the modalities and into the PACS or into the archive, they're coming in a DICOM format. And typically what's happening inside of the organization, let's say this is a hospital or health system, that image is being pushed onto the AI orchestrator, which is sort of that traffic conductor that Dr. Kottler mentioned. And the AI orchestrator is grabbing the image, it's de-identifying any patient information before it leaves the firewall of the organization. Once it's been de-identified, it will take just the study itself, the data, and send it into typically a very secure, HIPAA-compliant cloud environment that will pre-process and run this kind of quick scan to read it using the AI, and then it will return it from the cloud back to the firewall, and the orchestrator will re-identify that information so that it can then be associated with that patient. And then it can be provided either to the work list, that could be an EMR-driven work list, it could be a PACS-driven work list, you could have a smart work list product like a Clario or a Primordial. So the findings can be sent to the work list so that the radiologist doesn't have to kind of break their workflow and can just see it right there on their screen. It will also be sent to an AI widget. So if it's not integrated, clinically integrated with the workflow, you can also just use a widget and check that, and you can see the results. But what's really cool about this is that oftentimes the AI has read the exam before it gets to the rad. So this is happening, on the front end of the process, and that way it's helping the rad make a better read and providing them some guidance and saying, hey, you might want to look here, or this is something to point out, and it just helps them. And if there's not something there that the AI found, then it gives the radiologist a greater comfort level that, okay, maybe there's nothing significant with this case, so I don't have to belabor it, I can kind of move on to the next one, right? So it's really helpful from that perspective. So that's kind of the sample architecture. And then this is a typical implementation. And again, this is, this is just commercially available software as a service AI. This is not if you build your own or, other strains of this, but just sort of the things you can buy out there in the open market. And there's a lot of different vendors playing in the space. But a typical implementation is about 30 to 45 days. It's not super cumbersome. It's pretty lightweight on the facility. You really don't have to have a lot of hardware or CPU to run this. Basically, you just kind of set up a virtual machine on the customer side. You make sure you establish your DICOM connectivity. You install the AI tool or the widget. And if you're going to connect it to your work list, then you would do that. And then typically the software vendor down below is going to help you with installing the AI orchestrator and making sure that everything is communicating and flowing properly. And then doing some testing with the cloud servers to make sure that's all working properly. Once it's been tested, then you're ready to go live. So actually a pretty simple process that's pretty lightweight on the organization. And it's also pretty easy to support and not that expensive of an implementation. A few challenges and some things that we think you might want to think of from an AI adoption perspective is it's important to remember that this is something that at the end of the day is meant to help the clinicians do a better job of reading, to read more quickly, more accurately, with greater specificity, etc. So whether you're a radiologist or private physicians, they're employed by your facility, maybe they're teleradiologists or locums, you've got to make sure that the AI is going to work for them. In addition to the radiologist, on the left side of this example here, you have other stakeholders, which would be your techs, your nurses, your referring MDs, other specialties. hospital administrators that also are going to need information from this. So you've got a lot of stakeholders here, and you've got to coordinate this and make sure that everybody is making best use of the tools and knows how to utilize it. On the right-hand side, you've got your software companies, and they're obviously focused on developing the technology. But that's mainly where they're heads down trying to develop great tools here, right? But on your side, you've got to figure out how are we going to implement, integrate these tools. And it comes down to what we call change management, just making sure that you're thinking through all of these different scenarios. You may have multiple AI vendors in the mix, not just one. You may have in time a dozen or 20 different AI vendors. How are you going to coordinate all those different vendors? And then you've got, dozens, if not hundreds, of clinical and administrative stakeholders also that have to be able to have access to this and interact with it. So this piece in the middle, this change management piece, this is really where you've got to give some thought as to how are we going to design the solution? Which vendors are we going to evaluate? How are we going to do the due diligence and test these products? As Dr. Kottler said, she likes to always do a pilot on something to make sure it's going to work before putting it in live production. Managing the program, the project, training of the users, adoption, et cetera. Who's going to support the systems? Are the AI vendors going to support it? Or do you have someone from your IT team internally that's going to be the first call if something's not working right? You got to think through these things. But none of this is difficult. It's just something that we haven't done before because AI is new. So these are just some things to think about. So in conclusion, we want to thank you all for attending today. We think that in summary, the technology is really going to continue to grow. Radiology is the most IT-centric specialty within healthcare, and new tools, new technology, especially AI, are going to help create and drive new value within imaging. We talked about why AI isn't deployed everywhere yet, but we think that in the very near future, you're going to see a lot more of this coming into play, and it's something that it would be good to be thinking about your strategy now. And then the future of AI, again, AI is not going to replace radiologists, we don't think, no more than AI on an airplane replaces a pilot. But having the best of machine learning and the best of what the radiologist can do working together is going to result in better patient care. And that's really what this is all about. So with that, we'll conclude the session. We have about 15 minutes or so remaining, and we'll just kind of open it up for some questions. I think we had a few questions that I saw come in at the time. So if you have questions, please use, I think, the Q&A box at the bottom of the Zoom screen here, and just key your questions in there, and we'll be happy to answer any questions that you have.
Perfect. Thank you. Thank you, Mr. Humphrey and Dr. Kottler, for this informative presentation. So yes, we are ready for your questions. And I did see a question over here in the chat box, and it says, how fast will some of these tools roll into our daily lives?
So
yeah,
I can take that. It just depends on who you are and where you are. For this to be sort of standard of care, I think it's going to take maybe another year, because we've got to get through that consolidation, all of the issues with just managing our data. And we know that our IT systems in healthcare are like 20 years behind IT everywhere else. I mean, if we were really up to date IT, we could roll it out pretty seamlessly, get our RADs on board, get the change management going, but that's just not realistic in a hospital environment. So I suspect maybe in a year, but there's early adopters already. There's definitely people that you're going to see using it. I'm seeing more and more uptake of different AI algorithms. There's people that are using ones for stroke, especially, and there is an NTAP payment that you can get, a new technology add-on payment. So you'll see some early adopters using it in different areas. It's a crystal ball, but my crystal ball, as is my guess, is just saying maybe in about a year or so, you'll start seeing it more frequently.
Okay. Thank you. Next question. Do we see telerad agencies and outpatient picking up AI faster than in hospitals?
I can answer that. So yes. Why? Well, a lot of the products that are FDA cleared, that most people aren't going to use a product unless they're FDA cleared, and certainly no one's going to get paid for a product unless it's FDA cleared. And most of those products are CAD-T, or these triage products. And triage products are finding critical findings. Well, a teleradiology company is doing mostly acute work, and there's a much higher percentage of critical findings. And it's nice to be able to triage within those critical findings in a teleradiology practice or company. We've also seen that there's been starting to be some businesses that have come about that are combining radiology and AI together. There's a couple of businesses out there now that are advertising that, hey, I will provide you radiology services. It's a rad augmented with an AI. And because we can be more efficient and more effective, we're giving you a better service and we'll do it for cheaper. So with that, I think more teleradiology is starting to pick it up. Then there was the other one besides teleradiology. The question was again, Anita?
Outpatient.
Outpatient. Oh, yes. Okay. So outpatient imaging, one of the great things about outpatient imaging is that you have control. It's probably your risk system. It's your patients that you're communicating with. If there's any way to increase the amount of patients coming into your system, then that has an immediate effect. And so there are AI systems that help with scheduling. They communicate with the patients to get more patients into the system. We're seeing that in mammography. And then any changes that you make, it's easier to implement because it's your own system. There's not a lot of bureaucracy to go through. So yes, I would say both for teleradiology and outpatient, they're going to be more early adopters of this technology.
Great. Next question, why more AI models are for MRI and CT than in ultrasound?
Yeah, there are a couple out there for ultrasound that have been, they haven't been as much adopted. I think it's taken longer for some of them to get FDA clearance. I think some of it is just related to how did we start getting these models to begin with? These are AI vendors. The AI vendors in the beginning didn't have a lot of clinical expertise. So some of the things they chose were based on what data did they have accessible to them. And the data and the free data sets that were out there were more CT and even X-ray. And so when you start, if you don't have access to other kinds of data, well, you use what's free, and you use what, if you're not a clinician, you do what you think is going to be valuable. And most people think, well, what does radiology do? They read images. So if I have data and I think you read images, I'm going to combine those two things together and produce algorithms. And so you get a lot from CT.
What are your thoughts on AI in the marketplace?
I'll take that one. I think AI, if you've been to RSNA, obviously not this past year, but in previous years, it seemed like every vendor was having AI on their booth. And then the last year in 2019, there was an entire floor dedicated to AI. Literally, they filled up the McCormick Center. So there is a lot of interest, a lot of companies that are developing. There's a lot of investment dollars coming into this space. Again, radiology is probably the most IT-centric specialty within healthcare. So this is where a lot of the investments are being made. But there are some tools that are being developed that the primary benefit is for the RADs. It helps the RAD to make a quicker read, sign off on their report more quickly, make sure they didn't miss anything in the process. I think what you're going to see with those is that radiology groups are going to have to make some investments in those types of tools so that they can keep up, be more competitive, be more productive, and just kind of be on the level that everyone else is. But the things that help the radiologist just do their job better are probably things that are going to have to be paid for by the radiology practices. Then there's another set of AI tools that really have patient care benefits. They're helping to triage cases. They're helping to reduce length of stay, looking at very critical things like ICH and stroke and things like that. So if these are things that are, helping get critical care to patients more quickly, give them reduced length of stays, better outcomes. These are things that are going to help the health system, improve reimbursements, et cetera. And these are the AI applications that probably the health systems and hospitals are going to have to pay for. So I think monetization is probably the next phase of this. You got a lot of vendors out there and look up in search of a market, and not all of them are going to make it. But the ones that will make it ultimately are going to have to find a commercialization strategy for this. And we think that the RAD groups will be paying for things that help RADs do their job better, and the hospitals will be paying for things that, that the primary benefits accrue to the health system.
If AI is processing in the cloud, how would it secure my PHI?
Good question. So actually, we had a slide on that just a few slides back, and that's basically that the PHI never leaves your organization. So while typically AI is running in the cloud, it's what's happening is it's coming off your modality, going into your EMR, going into your PACS and your systems internally, and everything's staying inside of the firewall of the hospital or the imaging center. The only thing that's leaving is the image in a de-identified format. So there's no patient information that's being passed with that. And then when it comes back in, as we said, it's being re-identified. So your while cloud seems maybe a little bit scary from a PHI perspective, if depending on which product you're using and which vendor it is, there shouldn't be any PHI that's actually leaving your organization and going out into the cloud.
Okay. There seems to be 100 AI companies. How does one go about deciding?
Mm-hmm. Yeah, and it depends to what you're looking for. I mean, do you want to buy a product or do you want to partner with a vendor? And depending on which you're looking for, you'll go a different way, perhaps. So let's say you're just looking for a product. If you're looking for a product, find the one that's solving a problem that your physicians want solved. If there is a use case that is out there that they're looking for, see if you can find something that that manages that use case. There is, if you are looking to partner with a vendor, now that's very different. Then you're looking at the vendor themselves to see what is happening with that vendor. Are they a good group to work with? Are they not a good group to work with? Hold on one sec. Let me just decline this call. Sorry about that. And for that, I talk to the vendors a lot. I mean, I spend a lot of time when I'm in RSNA in that floor where we're speaking with all the vendors. If you ask a few questions, you can start to learn very quickly which are the vendors that are right for you and for your organization. Now, for me, that's a vendor that I can work with seamlessly. It's a vendor that's going to help me solve my problems and not wait for me to tell me about them. It's a vendor that I don't need necessarily a vendor that has a great data set because I've got a great data set, but if you may need that, you may want someone that has a very generalizable algorithm. So speak with the vendors because you'll find very quickly by talking to a few, which are the ones that are right for you.
So we have another question. So AI can help with post-processing of imaging data. How will that affect billing and reimbursement for post-processing?
So I can take that a little bit. There are some companies out there that are already using some of the codes or trying to use some of the codes for post-processing. I think ultimately you can't double use that code, right? Like, and you only use it once. So if you're creating 3D images, but then you're also getting quantified data about brain volumes or something like that, you can't use it for both things. I think ultimately we have to find a CPT code that is appropriate for AI. That those 3D post-processing codes were not created for AI solutions. Yes, they are being used for some of them now, but not with great success. In the end, it's all about finding the right business case. And the right business case is, well, in some cases, there may be some CMS payments. We're starting to see with the NTAP and the MCIT programs that CMS or government is willing to pay for outcomes. And that's new, right? People expect a certain level of quality and outcomes and they don't pay for it. So now we're starting to see that. So as we start to move to value-based healthcare, maybe there'll be more of that. But otherwise, it is probably going to be something, at least in the short term, that we're going to have to figure out what is the ROI for either, as Reed said, the radiology practice, or more likely the hospital system that will have to pay for it.
What are some useful non-image based AI tools?
I can take that one, at least start it. So there are a lot of things, obviously, in natural language processing that are just using the voice recognition. There's a tremendous, I mean, at the end of the day, that's the radiologist product, right? So the data that's in there can be used for so many different purposes. One, I'll give Dr. Kottler a shout out that her organization has developed a proprietary platform called RecoMD, which is, it uses natural language processing to basically kind of provide best practice recommendations for radiologists as they're reading, which is fantastic and helpful, and it kind of reduces the standard deviation from one rad to the next, make sure everybody's doing things according to kind of the gold standard. Another product there that doesn't use imaging is Rad AI, as an example, is a tool that helps the radiologist sign off on their report more quickly. So as the radiologist is dictating, it's actually building the final impression report at the end while they're dictating, listening to their findings and recommendations. So when they get to the end, they don't have to spend 2 minutes signing off on a report. It's already built for them. And that saves a rad a lot of time. If they're reading 60 to 80 exams a day, if they can save 2 minutes per exam, it's very helpful. And then there's a lot of things. Someone asked earlier about how AI is being used for radiology, billing, coding, automated pre-authorization, things like that. There are AI tools coming up everywhere, all around the imaging space. And I would say probably the majority of them are not image-based.
Have anecdotal examples of how AI has reacted to artifacts?
Yes, and it's going to vary by algorithm, right? Because if it's been trained on certain artifacts, then it's going to recognize those artifacts and not confuse them. So we've got an intracranial hemorrhage algorithm that we use, and there are certain motion artifacts that it doesn't detect very well. But for me as a radiologist, when it gives a false positive on something like that, it's a really easy one to bypass. It doesn't take any of my time. The harder things are when, if it were finding a false positive that I'd be confused on, like a really subtle density that is high density. Is it calcification? Is it hemorrhage? Those are the harder ones. But yes, it will mess up, I suppose, or not be very accurate on certain artifacts if it hasn't been trained on those. Now, the whole idea behind machine learning, although you can't FDA clear it, right now it's FDA cleared at one point in time, but in the future, what we'll be able to do is we'll be able to take those things that it's missing, feed it back into the system, so the next time it won't miss it. That's AI of the future.
Okay, and there's just one last question. It's where can you find a consolidated listing of vendors servicing AI technology?
The ACR DSI has a really great list. They have consolidated a list of, and it's over 100 now, for all of the AI algorithms in a specialty that are FDA cleared. And that's probably the first list to go to. I go there, and that's what I use.
Okay.
I would also add on that one that they were asking about the list for the vendors. We meant to post this, and it looks like the graphic didn't come up right. I'm going to just post it again in the window here. But we actually have a page on the Canopy website for an ROI analysis if you want to understand the business case for any AI. It helps you think through, how do you actually justify this to your organization? So that's something you can go and download off the website if you're interested in learning about the business case for it.
Perfect. So that concludes our webinar today. Thank you, everyone, and have a great day.